video so that if people can see you as I introduce you. I'm going to start the meeting and multitask with introducing you while I'm admitting people. We currently have 42 people in the meeting room, which really is, to me, an indication of the importance of the topic for which you're presenting. So for most people, Rene needs no introduction. She is an experienced palliative care clinician, and she started her palliative care work at St. Luke's Hospice and is now full-time at UCT in the interdisciplinary palliative care and medicine division. And she is the convener, as everyone knows, postgraduate diploma in palliative care. And she also is working at Fortescue in a volunteer capacity, takes up since COVID started 50% of her time in this volunteer capacity and providing the palliative care advice and consultancy to people requiring palliative care, both COVID and non-COVID patients, and as well as the support to people in the clinical field. So I'm really proud and privileged to be able to introduce Rene. And on this important topic, which she took the lead in developing a palliative care indicator tool for South Africa, which is one of the first steps that was found the development of the national policy framework and strategy for palliative care, that they believe.
Okay, wait, let me just see.
To your presentation.
Thank you, Liz. Thank you, everybody. I'm going to put my video off just for the bandwidth. And I also want to say thank you to Liz, who has supported me and who's been integral in the development of this tool. And this presentation forms part of the development of this tool. So I would really recommend feedback or please be open to provide us feedback because I can see there are a lot of very experienced palliative care providers on this call. So thank you. So the research team was Prof. Gwether, myself, and Dr. Alan Barnard. We received ethics approval. But I also want to say thank you very much to my expert advisory group who assisted us in looking out from the outside inside so to develop a robust and tool that hopefully will be used in the South African setting. Okay. So as you all know, the rationale behind this study was that with the World Health Assembly stated that palliative care should be within the continuum of care. And the World Health Organization says that palliative care should be commenced when patient is diagnosed with a life-threatening illness. And within that word, there is a tremendous amount of ambiguity. Life-threatening is defined as an illness that has a strong possibility that it can be fatal to a patient, and other healthcare professionals also uses the word serious illness, a condition that carries a high risk of mortality, negatively impacts quality of life and daily function, and has burdensome symptoms to the patient and provides caregiver distress. But as many of you know, working in a healthcare sector with young clinicians and many clinicians who have not been exposed to palliative care, there is ambiguity in these things, leaving many patients actually then not receiving the adequate care or palliative care being integrated at the right time. It also leads to a position where patients can be referred for palliative care where they are actually not requiring palliative care. Therefore, because of the lack of awareness amongst doctors about when a patient can benefit from palliative care and the lack of consensus around what is life-threatening, we need to develop a simple tool that can be used to identify patients requiring palliative care. A tool like this must be appropriate for our setting. It must be above all acceptable to healthcare providers. It must be ethically robust and correct, and it must be easy to be used in a clinical setting. This type of the ability to have a tool that can identify the palliative care population is very important when we're looking at funding and benefits patients receive. So we want patients to receive palliative care not at the end of life, not when they are pre-terminal, to receive the best outcome from palliative care. We want palliative care to be introduced when patients are diagnosed with a life-threatening illness. So we know there are a variety of tools available on the international arena. The most used tool is the SPIC tool that was developed in Edinburgh. There is the gold standard framework, WEPS, that also use as a tool. The American population use a CAPC tool. The same SPIC tool in Edinburgh, together with clinicians in Nepal, to develop the SPIC for lower income settings. And we are also aware that in Australia, they use a combination of the SPIC tool and the gold standard framework tool that can be used. But none of these tools are without their problems, and especially in our setting. So let us just look at a few of the tools that are available. Firstly, the gold standard framework uses the surprise question. I will not be surprised if a patient dies within 12 months. This tool also has general indicators and specific indicators, but it's quite a long task to identify whether a patient actually requires palliative care. And this tool on validation has found to over-identify patients. Therefore, it's not simple enough, and it can over-identify patients. The SPIC tool is a tool that was developed in Edinburgh. As you can see, it's a one-pager. It was developed through consensus and through doing a prospective file review on patients who present to a tertiary hospital unexpectedly. So unexpected admissions in a tertiary hospital. But if you look at this tool for our setting, you can immediately see there are some things that are very important in our setting that is not in this tool. The one that stands out firstly is infectious diseases. This group of in Edinburgh went on also to create a tool called the SPIC for low-income settings. Now, in palliative care, and especially to make sure that this tool is ethically robust and acceptable to both the public sector and the private sector, the SPIC list would not be appropriate for our settings because it makes assumptions to say, if it's not available, provide palliative care. And what is very important, we cannot allow palliative care to be an excuse for a healthcare sector who does not invest in proper, ethically correct resources that need to be made available for patients. Therefore, palliative care can never be an excuse for poor care. So when we look at tools and the tools that are available, we've got to see that there are general indicators for the tools, and there are also, for each disease, there are domains. So there's a cancer domain or disease-specific domains, cancer domains, dementia, frailty, other respiratory, heart failure, kidney, liver disease, and other conditions. Within these diseases, there are also then disease-specific indicators. So when we are looking whether patients require palliative care, there are both general indicators and disease-specific indicators that can be used to identify palliative care patients. This is the CAPC tool that is used, and I'm not going to spend a lot of time on it, but again, you can see there's a combination of the surprise question and more disease-specific questions. These tools have been used to develop referral tools, and from using this referral tool, I can already tell you that we were not reaching all the populations we are serving in a palliative care service in Groote Schuur Hospital. So the aim of this study was to develop South African consensus on indicators for palliative care. Firstly, we identified panelists who are representative of the South African healthcare context, to survey these panelists, to develop consensus through a Delphi study or the Delphi technique, and then to have an external group provide their input on the consensus we reached. So how did we go about this? Firstly, we used a Delphi technique. Now, the Delphi technique is known to have the lowest, in a local setting that we can't really say that it's going to give us the validation of it, and it doesn't give us the best evidence. However, we can justify using the Delphi technique for various reasons. Firstly, it's good to start off with a Delphi technique to develop initial consensus on what the indicators would be. It can then go forward to validate it further. We also didn't have extensive resources, and we also know that we are working with a very vulnerable population. So although a Delphi technique has low-grade evidence, we can conduct our Delphi technique in such a way that we develop a rigorous study. And what did we do to ensure that there was rigor and transparency in the study? Firstly, we had an anonymity when we sent to the panelists. When we had our expert advisory group, we could not, in a focus group, ensure anonymity, but when we sent it out to the panelists, we could. We included purposely negative statements. The planning and the process of the Delphi technique was transparent and was followed. There was clear definition on how we were going to develop consensus, and how to deal with non-consensus was predetermined. The method for consensus building was used as described by other studies. There was also transparency whenever we found that there was non-consensus or when we had to look at things critically. We used an external group for review, and as we went along, we critically reflected with our expert advisory group continuously on things we found were not quite clear. One of the problems with using a focus group and trying to develop consensus is bandwagoning, and we prevented bandwagoning by ensuring our expert advisory group were firstly well educated or had enough literature to understand what this tool was all about, and that they actually had to write down their thoughts before the aspects were discussed. So writing down ensured that they were not influenced always by other people's decisions and how they were saying aspects. Our expert advisory group were multi-professional. We did not only ask for doctors, we included nurses, allied healthcare professionals, and social workers. We ensured that they were experienced healthcare providers, and when we chose our panelists, we actually asked our expert advisory group to choose the panelists to ensure it was peer-reviewed experts. And we wanted these to be clinicians who are actually working with palliative care patients. Our expert advisory group were also clearly informed on the process that were followed. They were provided with literature, and they had enough time to consult with us to determine how we were going to enjoy a transparent project. Okay, so again, I want to say thank you very much for our expert advisory group. So what was the technique we used? Firstly, we had thought we were going to start with Delphi 1, but we actually had to start off with Delphi 1A, where the role of the indicator was clearly decided on why we needed an indicator tool. I'm going to go through all these steps now in detail to show you how we actually reached our final tool. Firstly, on the first meeting with our expert advisory tool, they wanted to be clear on what is the role of a palliative care indicator tool. What does the tool need to indicate? And you can see there were many aspects that were written down and many views on what actually the role is of a palliative care indicator tool. We then surveyed our expert advisory group and we sent it out for consensus. We had 8 responses from them, and the final consensus is that the aim of an indicators tool is to identify adult patients who have serious health-related suffering due to life-limiting or life-threatening illness whose health is deteriorating. It is likely that the patient's death will be a consequence of these conditions. Very important, it is a generic tool for the South African setting to identify patients who will benefit from a palliative care approach in conjunction with usual care by the treating clinicians. And it may lead to a palliative care referral to optimize care. The next step was to do a Delphi 1. What was done here? All our expert advisory groups provided us with names. They had to write down general indicators, the domains they thought that need to be included, and if they were an expert in a domain, to write down the specific disease indicators. A survey tool was created, and this was again circulated to the members, and then it was only sent out to healthcare professionals who the expert advisory group identified. The panelists we sent out to 160 healthcare professionals, and you can see who they were and how varied they were. So it wasn't not just medical doctors, but also social workers and professional nurses. Unfortunately, like all surveys, we had a poor response rate. We only had a 37% response rate. It was anonymized. We used a red cap survey method. We reminded healthcare professionals, but again, because it was a survey, the response rate was poor. We then went on and looked at Delphi 3 and 4. The expert advisory group reviewed the findings. A draft tool was again developed, which was then represented to the panelists, to the 116 panelists. Here the response rate was even poorer, and this can indicate many reasons for such a poor response rate. We only had 14 respondents, but the 14 were all in strong agreement except for a few details, and we will talk about them in a little bit more details. Fractured femurs and dementia and frailty, severe weight loss, and in the hepatic disease patients, bacterial peritonitis and recurrent variceal bleeds. Okay, this tool was then sent out for external review to the University of Edinburgh. We had very detailed feedback from Dr. Boyd in Edinburgh. And some of the main things that she said we should be very aware of were negative statements like futility, rather using not responding. One aspect that she really recommended and that we discussed with our external review group again was to include loss of communication as a disease-specific indicator for dementia patients. But we are not finished actually with this external review, and we have a meeting with the SPIC group again in 2 weeks' time. So now what I want to do is I want to go through the domains, the general indicators, and the disease-specific indicators as they were developed. So firstly, the domains. And as I said, we were already aware that the SPIC tool was not covering all the domains of diseases we are seeing in South Africa. Domains that we then included were infectious diseases, hematological diseases, trauma, and also that was included from the expert advisory group were mental health and gastrointestinal diseases. All of these had consensus that they should be included, except mental health and gastrointestinal diseases. Although trauma had a low response rate and there were controversy whether it should be included, the expert advisory group still felt that trauma must be included as a domain in the South African setting. So what were the general indicators that were sent to as a survey? As you can see, our expert advisory group came up with a long list of general indicators for palliative care. The first problem with this is that it is too long and will not make a good tool. We then asked our expert advisory group to actually try and match it to the SPIC tool for general indicators. And actually they found that they could list all this list of general indicators that reached high consensus with the general indicators as indicated by the SPIC tool. In this general indicators, we also included purposefully negative statements, like the patient has advanced old age. Now, this is generally known among palliative care providers as not really an indicator for palliative care. However, people scoring it high indicates again the misperceptions around when palliative care should be indicated and makes probably the argument that we need a tool, a robust tool for clinicians to know when to refer palliative care even more important. So after our discussion and our linking our general indicators with the tools of the SPIC, these were the general indicators that we came up with to ensure that these are responsive for our South African setting. Okay. Now the disease-specific indicators. I can't go through all of them, but what I want to go through is the ones that show or demonstrate actually how these were developed. And I think the first one that everybody is sort of knows palliative care, and it's sort of a default that everybody's sort of okay that cancer should be an indicator for palliative care. There was no doubt that cancer would be an indicator for palliative care. You can see sorry, I just want to go back there. The specific indicators that our expert advisory group gave, and then how the panelists responded to whether they agreed or not. Now let's just look at cancer. Firstly, what does the SPIC tool says? Functional ability deteriorating due to progressive cancer. In our setting, cancer patients are not always seen by the same doctor. So the slow deterioration of patients are not well documented and not well observed. Let's look at SPIC lists. Too frail for cancer treatment, treatments for symptom control only, or treatment is unavailable. Now again, this dynamic and this nuance that says we cannot make palliative care an excuse for poor health care. Therefore, we cannot say it's okay to provide palliative care because we're not providing the other treatment. We as palliative care providers must be very strong advocates for the best possible care for patients and never be a default for poor care. In our draft 1, malignancy is not amenable to curative surgical or radiological interventions. metastatic cancer with symptoms, progressive metastatic cancers, and too frail for oncological interventions. The expert advisory group felt that the word metastatic is a term that is well understood and well accepted by South African healthcare providers, and therefore must be in our tool. The external advisory group said, Hawkeye, you can't just use curative surgery and radiological oncological interventions. There are many other interventions patients can have as innovative therapies are coming forward. Therefore, we must just state malignancies not amenable to curative treatment. We must also say progressive or metastatic cancer with symptoms. And of course, the one too frail for oncological interventions is very easily accepted and appropriate for our healthcare settings. Very important is that the SPIC tool talks about cancer. But because we included hematological diseases as well, we said that our tool should talk about solid organ cancer. The hematology, our groups and our expert advisory group were very clear that this group of patients should be as a domain, as a separate domain within our tool. Healthcare providers forget that these patients, they are seen in very specialized clinics, but the alert must be that they should also be receiving palliative care, and especially when it comes to benefits, and especially when it comes to providing care for these patients when they are outside the big centers. As stated, it's not included in SPECT, it's not excluded in SPECT list. And the external group said, be careful of those negative statements like failing or futile, and rather state not responding. Therefore, we've got in our SPECT, in our indicator tool, we've got hematological cancer with recurrent admissions for transfusions, infections, and bleeding, hematological conditions or cancer with deteriorating clinical condition and not responding to best available treatment. Opening that patients then can actually receive the benefits and the care that they need, even though the hematological condition is not just a cancer. Dementia and frailty, which is a very vague area with very vague nuances that we've got to be very aware of, is probably one of the conditions that really requires palliative care and where we need to strengthen palliative care for this population. Again, very fine little nuances that we need to be aware of. Probably the progressive and the final outcome was that progressive deterioration in physical and or cognitive function, progressive difficulty communicating, or progressive difficulty swallowing. And therefore, that was where the expert group to say to us, please include communication as well, because these patients are well known to withdraw and to interact less, and therefore it's a very good indication of deteriorating health. Also to include stroke. At first we thought, should we include stroke? And however, with our disease burden, we felt that we must include stroke patients with significant loss of function and ongoing disability and dependency. And of course, recurrent pneumonia, breathlessness, and or respiratory failure for these patients. Now, infectious diseases was not included in the SPECT. And in our South African setting, you are probably aware that we cannot not include this. However, there's still a huge resistance to sort of say this patient with a HIV or TB actually now requires palliative care. So again, not included in SPECT. Infectious diseases have been actually included in SPECT lists, And what I perhaps like about them is that they are more specific about age-related conditions. However, this tool must be acceptable to our clinicians and they felt at this stage not to include that, but to use general terms for HIV and TB. HIV with deteriorating clinical condition and failing the best available treatment. And the same for TB. And not to just say all XDR or all MDR TB patients require palliative care, but to actually see how, because patients fail TB treatment for various reasons, and with our better drugs available, to perhaps just say patients actually failing this best treatment should then receive palliative care. Now, trauma, and I'm very, very fortunate that we actually had a surgeon and emergency health expert advisories on this group. It is a place where we forget that palliative care needs to be delivered, and it is a place that there is a huge need for palliative care, especially in the South African setting. It was not included in SPHFM. In the SPHFM list, they place trauma as surgical conditions. But what is very important is that we state very clearly that severe burns patients actually require palliative care, and that brain injury patients with clinical deterioration with no further benefit from surgical interventions actually should require palliative care and be referred. Now, all the disease-specific indicators, I'm not going to go through all of them, and I will make this tool available for comment afterwards, but I thought I'm just going to stay a little bit with renal disease. Now, very important, and I actually just want to go to the previous one, sorry. Is that these were the indicators as identified by the expert advisory group, and that there was quite high consensus on that this group should, these are the patients. At the end, when through looking at it all, reflection, working with our expert advisory group, working with our panelists, we actually found that the tool that SPHFM and SPHFM and our final tool will be the same. So what have we actually achieved then by even doing this research? Actually, it's the process to make sure that we are all on the same page, which is actually an excellent outcome to say this is even in our South African setting, excellent indicators for palliative care and should be used. So this is our final tool. And while you are looking at this tool, you will see one more very important aspect of the tool. Because of the fear of clinicians that patients will not receive the best possible treatment, and that we want to ensure clinicians to first concentrate on reversible conditions and to look at the disease itself, we wanted to make sure, and reversible factors in diseases, to look at the diseases before they just look at general debility. The fear from clinicians that patients will be seen as frail, not doing well, oh, they're for palliative care, is very high. And therefore, as the expert advisory group really recommended, and we critically reflected on it, is that the disease-specific indicators should come before the general indicators. So that is a big change on swapping the two around in comparison to the SPHFM and the SPHFM. This is a bit controversial, but I think we need to try this out and find out what other people and palliative care providers are thinking about swapping our disease-specific indicators with our general indicators. So in conclusion, the study has resulted in an indicator tool relevant to the South African setting with consensus from specialists across disciplines. Very important, multidisciplinary. it is recommended in our national policy framework that we need to be able to define our population. It is more suited for the South African policy to develop SOPs than the UK one and for the developed world documents, that developing world documents. We cannot underestimate how important the process is, and I think sometimes perhaps the process is as important as the outcome and the final outcome, to develop consensus among palliative care providers and with providers outside the profession to say, yes, these patients actually require palliative care. We need to validate this tool. We can't just leave it at this, and we're going to need to build and strengthen very strategic partnerships with all our disciplines to validate this tool. And in the validation and in the process of validation, try to integrate palliative care and strengthen the palliative care services for these patients who have been identified. Thank you. And if you want to have a look at this tool, please email me. And if there's something that's really worrying you, and because I know there's very senior healthcare professionals on this call at the moment, email me so that we can again do this critical reflection so that we can get a valid and robust tool that's really addressing the needs of South African population in order for them to receive palliative care at the right time, not too early and not too late. Thank you.
Rene, thank you very much for a really excellent presentation with being able to summarize a very complex process in such a short time. I'm going to open the floor for discussion and questions. So if you would raise your hand so I can see who is asking. Riette, if you would like to go first.
Hi, thank you, Rene, for that very detailed discussion. I just wanted to ask in terms of how we are going to be using this SPIC document. I know with the Edinburgh SPIC document, survival has been correlated with having one disease-specific criteria and 2 general indicators. I've often found it very difficult, and I've often found it hard for to have people commit to how many indicators qualifies for a referral. What has been your thoughts on that with this process?
Yes, and I think to give it a number and to be very specific about the number is something that the newest SPIC, and I think the SPIC group is also said that perhaps just one indication is enough. But I do think that it's going to need validation, and that most of the time patients will have more than one indicator. But I hear that you say a 2-1 ratio or a 1-2 ratio. I think it becomes too detailed, and I think we might be too specific. We've got to use this as an alert for doctors, more important, to say, think about palliative care and start discussing the palliative care process than making it, 2-1, 1-2. I'm very concerned about that. Liz, do you want to comment on that as well?
So, Rene, I'm very happy with your response. I think that mostly it's putting it out there so people think, does this person need palliative care?
I think, sorry if I can just respond. I think it's practically speaking, if we want to sensitize people to the to the integration of palliative care in a patient's care, you can't just have general indicators. Like you mentioned, the same as the policy with old age. You have to have at least one disease-specific indicator, and then the fact that the person has deteriorating function or increasing dependence is in a way indicated by the general indicators. So there needs to be either a 1 and 1 or a 1 and more than 1 concept. I'm just saying in terms of a concept.
No, and I think we can review that, and I agree with you when it comes to funding and benefits, that we're going to have to be very specific about that. Thank you. I think I hear you around that. Because we do know when it comes to benefits, funders want that very specific. They want very specific indicators for that.
Thank you, Rene, and thanks, Riet, for a really important question. I'm going to ask Janet to put her question or comment, and then Tilo in the chat, you put a question about TB. So Janet first, and then Tilo.
Thanks, Rene, for all the hard work and the very clear explanation. The thing that still worries me is that there are two kind of tracks going on here. One is that palliative care is indicated from diagnosis of a life-threatening illness. And the other is these tools are when you're some way along the course of the life-threatening illness. So I think it could be confusing for people. And I think we have to maybe, well, my suggestion would be that we distinguish between referral and specialist palliative care and palliative care that the diagnosing person and treating person would offer. Otherwise, we're going to get confusion between those two concepts of from diagnosis and then applying the tool and palliative care further along the path. And then my other comment is obviously under infectious diseases, we need to add COVID now.
Thank you. Thank you, Janet. So I will come to COVID, and I think COVID has taught us to reflect further on infectious diseases and to include a broader statement about all infections not responding to best available treatment. But then we've got to be very careful about that. But COVID and the rule that's being used for infectious diseases has definitely been applicable in the COVID pandemic. On your response to a referral tool versus an indicator tool, it's very important. And this tool is indicated for patients who are diagnosed, as I want to actually go back to that beginning slide, what is the aim of the tool. And I'm just going to share again that with you. Sorry about that. Oh, gosh. Oh, gosh. Let me stop that sharing. I can't find it now, but the aim of the tool is when the diagnosis of a life-threatening, when that cancer becomes life-threatening, that is the aim of the tool, to identify those patients.
Rene, I'm also just going to make a comment that we're not being referred people who are being diagnosed as life-threatening. So this is a sensitization tool as well. So I do agree with Janet, we may be not going to get early enough referral with the tool that doesn't say from the time of diagnosis. But as people become more aware of the tool and more aware of palliative care, and more people are being trained in palliative care, the early palliative care we hope will be provided by the treating clinician. And so, yes, Janet, the SPHFM was a referral to a palliative care service and not just implementing palliative care.
Thanks, Liz. I think, well, my dilemma would be solved if one used it in conjunction with that continuum of care graph.
Yes.
Where people could understand that.
Yes, that is very useful. Thank you. Rene, did you want to say something more about COVID, or shall we take the TB question?
No, we can take the TB question. I think it comes very much together with that.
Tilo, are you able to join us and give us you put a question up in chat. I'll look for it for you. I can find the conversation. Tilo. Will palliation of adverse drug reactions in TB treatment, including drug-resistant TB, be considered?
Thank you. So definitely, I mean, that's why for the infectious diseases, we made it a broad statement, and we can say TB with deteriorating clinical condition and for failing the best available treatment. That population you've now just described falls within that bracket. Then these patients should actually be receiving, if they have deteriorating clinical condition and they are failing the treatment. So with other words, they cannot actually they cannot maintain that treatment that was given to them, or they can't take that treatment, then they are failing that treatment, and that population will then receive palliative care.
Thank you. I know, Riet and Janet, you've still got your hands up. Toby Finger.
Thank you so much, Liz. I think I just want to go back a little bit to Jeanette's question. This may not necessarily require an answer, but I think if we continue to talk about palliative care at the beginning of diagnosis, prevention becomes critical to be a conversation that we must have. Rene, the tool is extremely brilliant. I think for me, the only concern I have is usage. And particularly if you think about the public healthcare setting in terms of how user-friendly you make it, in terms of being disease-specific. But I do want to request, can we not miss the opportunity of emphasizing prevention as part of the awareness at the point of diagnosis? And then my second question is around the TB in terms of, I see the focus is on clinical deterioration, or if the person is failing treatment. I also want to say, if we continue to spread the message of prevention around palliative care, I think that's the point where we will try to draw people who are not necessarily specialists in palliative care to be able to start taking part and participating in palliative care. I think that is just my concern. I feel like this is really for people that are already trained in palliative care, and I don't want us to miss the opportunity to say, how do we then bring the broader audience that is not yet palliative care specialists but are already providing care in some form of way?
Yes. So I hear you, and I do think it's very important that healthcare professionals are trained in basic palliative care and should be able then to use it. But even any healthcare professional, if they look at the tool, the tool is so that they can look at things of frailty or deteriorating health, and then start going, does this patient actually then justify palliative care? Can I give that to you? And I agree with you that prevention is fundamental at that diagnosis. And as we said in our definition, it is done alongside treatments that are intent for cure. We are not, and that's why the aim of that tool clearly states why we are including curative treatments as well. We're not saying palliative care, nothing further. But we can also not say that all cancers require palliative care or all HIV patients require palliative care, because we might then not have the resources to provide it to that population who are actually now failing care and deteriorating. Although we can apply the approach of palliative care, which is a brilliant approach, to those patients, to all HIV patients, we cannot say all HIV patients require palliative care or all cancer patients require palliative care. We must say cancer patients with progressive metastatic cancer who are not responding to treatment, those patients do require palliative care. And I know this is a very controversial point, and I would like further opinions on it, because it is standing between clinicians who are very afraid of integrating palliative care and sort of saying we are providing palliative care for everybody. So I do know this is a very controversial point. Yeah.
Thank you, Rene. And I think this is going to be an iterative document, and there's going to be evolution of the document as there is better awareness of the application of palliative care and as better skills come through for palliative care. And also this document is not supposed to be the final advocacy document for all palliative care. It is only an indicator tool to be used as a prompt for clinicians as to whether their patient may require palliative care. And I think for me, the thing is that a clinician may be faced with a patient and they're looking and they're thinking, what can they do? And they've been trained in curative intent, so they don't think about the palliative intent. So if they've got this one-page, simple to use tool on their desk or in front of their eyes, they can think, oh, but maybe we should start the symptom control and the counseling and the palliative care, or maybe we should ask for a palliative care consultation and opinion to tell us what else we could be doing. Okay. Toby, your hand is still up. Do you want to ask another question? And
No, apologies. I'll bring it down.
In our comments, I see, Margie, you were talking about the bow tie, which I think is a little bit different to what the indicator tool is trying to do, but it's talking about how palliative care does get integrated and applied at the right time for the right person. So would you, Margie, like to comment on that?
Liz, so maybe just to say that I think there's a difference between referring a patient to a palliative care service and a patient receiving palliative care. And so I think people can have access to palliative care by the primary care provider, or if resources allow, a palliative care service from the time of diagnosis. I think it's different to referring a patient to a palliative care service. And so that bow tie, to me, works well. Also, for example, within the context of COVID, where, you know, a patient might benefit from palliative care, but in fact does survive. And so the bow tie works well. And the input required from a palliative care clinician would be less at the time of diagnosis and becomes more, probably more over time, which is also well described as bow tie. So I think I'm just concerned that the indicator tool, again, you know, speaks too late to some people.
Yeah, and thank you, Margie. And it's this balance we need to try and get right, because that was why it was so important for us to have people looking from the outside in and us looking from the inside out, from when palliative care should start. And as you know, there is huge resistance from many people to even start the word using the palliative care word. And I think as Liz said, it's an iterative document, and perhaps internationally these indicators will step back and, you know, go further to redefining life-threatening. But many clinicians are seeing patients with metastatic cancer with symptoms still not wanting to even think the palliative care approach yet. So it is defining, getting that balance right, and that is the difficulty of trying to find out how do we actually then define the population we are serving.
Thanks, Rene. I'm also going to come to a couple of comments that have come up in the meeting chat, with Jane Cunningham identifying that now palliative care has been highlighted during COVID. Younger doctors are now referring almost as a dumping zone with vague referrals. So the South African tool will be great to make palliative care referral a thought through professional referral. I like that comment a lot.
Thank you.
And I like Riette's challenge that now we're going to validate and test the tool.
Yes, and I think for that we're going to require a lot of stakeholder involvement and especially to make and I can't iterate it more how important the process is with the clinicians who are not trained in palliative care, who are very specialists in palliative in their disciplines, for them to assist us to develop an objective tool. And as much as we as palliative care providers want to bring the tool earlier and have earlier and earlier referrals, there needs to be a balance between, or seeing the patients or a palliative care approach, there needs to be this balance. And I think this balance is so difficult to get right.
Rene, I think this has been a really robust discussion and an excellent presentation, and I'm just so grateful that you took the lead on this particular research project that was so needed in the South African setting. And I see the endorsements and the chats that are coming through are also indicating how valuable our palliative care colleagues and colleagues in other fields will find an indicated tool. So I'm going to, seeing no more hands, I'm going to close the meeting and say thank you very much for an excellent presentation.
Thank you. And please, if there's any things that you want to email me about, email it to me, because as I said, this critical reflection of the tool is very important to ensure that it's a better tool. Thank you.
Well done, Rene, and thanks.